as a practicing clinician that we spend so much time talking about money and not about health. And I think my first tweetable soundbite is, we have to change this discussion from how much we spend to how well we spend. Because no one, I think, in the room would disagree that $3.7 trillion, there's enough money there, and we're just not performing in that way. And since I did not go to medical school to learn how to save people money, I went to medical school to learn how to make individuals and populations healthier. I think that as opposed to just looking at that dollar, you look at what you're getting for what you're spending, right? So I have felt that if you're telling me that we're spending more on drugs and less on hospitalizations, which is exactly the case since 2007, I think that's a good thing. I'd rather give someone a pharmaceutical than visit them in the hospital. So we have been trying to figure out ways to engage patients to behave better and be healthier in the real face of a health insurance system that's making my patients pay more for everything. So it's not that they're making people pay for the things that they shouldn't be doing. In the case of diabetes, my patients are being asked to pay full price in a high deductible health plan for the things I beg them to do. And more importantly, the things that I am benchmarked on. So my patient in a high deductible health plan has to pay full price for her insulin, full price for her eye exam, full price for her foot exam, and full price to go to her lab to get her hemoglobin A1C checked. And if that's not bad enough, since half the people enrolled in high deductible health plans don't have the money to cover their deductibles, my patient gave me permission to tell you that she said, I'll either see you next year or when I'm in the hospital, because she can't afford to do those things. So how about instead of having these blunt instruments like deductibles, we have a benefit design that makes it easy for patients to do the things that will keep them healthy and makes it hard for them to do the things that they shouldn't be doing. And we're lucky enough or unlucky enough to have 30% of our spending go on things that don't make people healthier at all. So I'd much rather have the focus on the $1 trillion of the things we shouldn't be buying as opposed to arguing about a life-saving drug that may be too expensive. I would love to get to that point. So what value-based insurance design does, as opposed to most Americans in the room who pay their cost sharing based on the cost of the service, we set cost sharing based on the value of the service. And for most who haven't heard this before, one of the most popular implementations of the Affordable Care Act that was mentioned earlier is most Americans do not have to pay a penny for 80 evidence-based preventive services. And that is the best implementation of value-based insurance design on the preventive front. So we have a success there. We have not been able to pull it through as well on the chronic disease side. So value-based insurance design, largely driven by the private sector, which said, maybe I should lower my cost of my insulin and my statins and my drugs for HIV, has kind of caught rare bipartisan fire here in this town. We now have a Medicare Advantage demonstration that allows VBID principles in all 50 states starting in 2020. We now have a very strange bedfellow multi-stakeholder coalition to allow high deductible health plans to cover services like insulin on a pre-deductible basis that hopefully will move forward. And I think it's unusual, maybe one of the reasons why I'm here is very few healthcare ideas can get someone from the health plans and the pharmaceutical companies and the PBMs to say, it's probably a good idea to not have my patients have to have a bake sale to afford her insulin or to get a cancer drug that was designed to treat her specific tumor. So we want to reduce cost-related non-adherence, but be fiscally responsible at the same time to make sure that we're not buying the things that we shouldn't be buying.
Well, give us some examples of the things we shouldn't be buying, because I think, you mentioned 3 stakeholders that agree with that, but I also think some patients might, whether because they are not informed or because they genuinely think they want those services, they might want, vitamin D testing or something like that.
So we're fortunate enough that the U.S. Preventive Services Task Force, which is an organization that determines those services that are high value that must be covered full price, they also have a rating called D for services that you should not do at all. So cervical cancer screening under the age of 21. Doing prostate cancer screening over the age of 70. Doing other certain types of diagnostic tests are supported not only by evidence-based groups like the task force, but because of the Choosing Wisely initiative that some people might know, that professional societies themselves are basically saying there are certain things that we shouldn't be doing, like antibiotics for viral infections and other types of things. And if we could just chip away at a small part of this low-value care, we could buy a lot of insulin and eye exams for diabetics.
But are doctors prescribing that stuff, or are patients asking for it?
So that's a really good question, whether it's demand side or supply side driven. I think most of the low-value care is supply-side driven. And one of my favorite quotes is, "It's difficult to get a man to understand something if his salary depends on him not understanding it." So if you are fee-for-service and you're on the fence or not aware of the most latest guideline, you're probably going to do more. And Olga, as you point out, in America, it's in healthcare, more is typically better, and we have to change that idea that sometimes doing things is not helpful to the patient. And we're working very hard across multiple stakeholders to understand that the only way we're going to be able to deliver those evidence-based services that I beg my patients to do is we're going to have to basically start chipping away at the billions of dollars that we're spending, start on the easy ones like vitamin D screening and D-rated services, to be able to create this headroom to buy more of these drugs and other services that people cannot currently afford.